Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
In today's episode, we are starting our highly anticipated leukemia series, this time focusing on AML.
Yeah, I'm really excited to get into this series. We're going to talk about myelodysplastic syndrome. We're going to talk about AML. And in this episode, we're going to provide a good groundwork intro where we talk about the idea of this thing called CHIP that everyone's probably wondering about or have heard about. And we'll go through it, and it'll really help you understand the pathogenesis of the diseases like AML and MDS.
Yeah, when I was in residency training, this is what the hematology service was AML and leukemia, acute leukemia treatment. I really wish that I had had this sort of ground up basis for understanding it. And so I'm excited to get into the series too.
Absolutely. And I can't even begin to tell you how many messages we've received over the last couple of years on Twitter and Instagram and via email of people requesting a series on this. So I'm glad that we're finally getting around to it. So without further ado, let's roll that show. You guys, I know that we're about to start a new series, but speaking of new series, Love is Blind UK. Vivek, if anyone's watching, I know it's you. So what are your thoughts?
This is a fantastic TV show. So when we think about the Love is Blind series, the US version's a little bit trashy, and I'm all about that. I'm all about the trash. But the thing that the UK series does is it has people on the show who are in their late 30s, mid 30s, early 30s. So it's just a different population of people who are a lot more mature, and they're very good at communicating, and the drama is somehow more interesting, and it's just so much less trashy. Could not recommend it more. The weddings are actually very good too, so I've already finished all the way, so I'm waiting for the reunion show, which is very important. Ronak, have you started watching it? I know you guys are definitely watching this too.
Yeah. I'm about halfway. As you know, I've started a new job, so that's been taking up a lot of time, but I've still been making as much time as I possibly can because this is a priority if we can get to it. So I agree. I think it started a little bit slower. Everybody just seemed so much more kind and courteous in the beginning. It wasn't that same sort of vicious thing that we see in the US version, but it's slowly coming out with time, and I'm all for it. I don't want to give away too much. Dan, you need to get on this. This is going to be something we'll be talking about, I'm sure, for a long time.
Yeah, maybe this will be the season I actually start watching. Right now it's fantasy football draft season, so I am swamped with that and got a couple of leagues that I need to really focus on, but maybe after that.
I do want to say, too, that Dan is the sophisticated version of me and Ronak. He goes to the symphony and stuff like that, whereas Ronak and I are sitting at home watching Love is Blind UK, just to contrast Dan and Logan compared to Ronak and I and what we do with our spouses.
It is what it is. I'm not ashamed of who I am.
Nashville Symphony, shout out. It's a great show.
You guys, I'm also excited that we are starting a new series today and going through things like MDS, AML. Today, we're focusing on the first part of that conversation, those letters that people may have seen, CHIP, CCUS, ICUS. What the heck does any of this mean? And we're going to get to talk about all of this today and more. So Vivek, do you want to start us off with a case, and then we'll use that to guide our discussion today?
Yeah, let's do it. So this is actually a case of a patient who I saw a couple days ago, and I just thought it was actually perfect timing that I bring this up now. So we have a 71-year-old male who presents to hematology clinic for evaluation of macrocytic anemia and thrombocytopenia. He notably has a history of gastric bypass 12 years ago and coronary artery disease status post-CABG 2 years ago. Overall, he's felt well without any new symptoms. His labs are notable for a white count of 6, a hemoglobin of 11 with an MCV of 105, and his platelets are low at 110. He had a workup for anemia with his primary care doctor, including iron studies, B12, and folate, which were all unremarkable. He had an SPEP sent, which showed an IgG-M spike of 0.5 and normal free light chains. His CMP was unremarkable with normal kidney and liver function. So we have this guy, he's got a macrocytic anemia and mild thrombocytopenia with a normal white count, and this IgG-M spike of 0.5 with normal free light chains. What are your initial thoughts as you approach a patient like this, coming from our two resident expert classical hematologists?
Yeah, and it definitely something that ends up in our clinic a lot, right? We end up seeing these cytopenias of unclear cause, And I'm glad you mentioned there's an M spike because like almost everyone has those, it seems, when I see people in clinic. Definitely go check out our MGUS episode at the beginning of our myeloma series for more information on that. But suffice to say, the findings here don't warrant additional workup at this point, just some monitoring. But whenever you're faced with a patient with cytopenias, you always want to try and establish a timeline. Figure out how long has this been going on, over what period has this been progressing. So take a look at older labs if you can find them, try and get them from the PCP or other facilities if you can. And next, you want to look at the differential. So the sort of differential cell count, breaking down the subtypes of the white cells, making sure that there aren't any atypical cells, absolute other cells, or leukemic blasts present on that differential. All of those things are ways that blasts or these very immature leukemic cells might be represented on a differential cell count, depending on the counter. And so keep an eye out for those types of cells. If there's a macrocytic anemia, so if the MCV is elevated and another cell line is down, always start with reversible causes, things like nutritional stuff, but keep those primary bone marrow issues in the back of your mind. Macrocytic anemias often will happen during these primary marrow processes like malignancy. Whenever there are multiple cytopenias, again, these nutritional deficiencies that we think about are vitamin B12, folate deficiency, and copper deficiency. You definitely don't want to forget about copper, particularly in someone who has had like a gastric bypass or anybody who's on chronic zinc supplementation. Copper deficiency in particular tends to mimic myelodysplastic syndrome, or MDS as we know it. After that, you want to think about infectious causes and medication causes and other sort of toxic influences that might impact the marrow. So you want to rule out viral infections like HIV, hepatitis C, Hep B, sometimes Epstein-Barr virus, CMV, things like that. You also want to take a really good medication reconciliation, a good med history, and include supplements on there too. You want to make sure that the start of these cytopenias didn't coincide with the start of a new medication. A lot of antibiotics, antiretrovirals, other medications like Hydrea, all of these things can lower the cell counts. Chronic alcohol use, that's directly toxic to the bone marrow. So that too can lead to a macrocytic anemia with some thrombocytopenia, especially if somebody's got some liver disease and their spleen's enlarged. And there are other drugs out there too that can cause cytopenia. So take a good social history, try and see if there have been any toxic exposures. You have to evaluate for liver disease, as I was alluding to, talking about alcoholism. The liver has a lot of roles. One of the things it does is it produces the hormone that tells our body to make platelets, right? So if the liver is not functioning well, the platelet count can be down. It can set people up for easy bleeding. The anemia follows after that. And it can even have an influence on the white cell count, depending on how big the spleen is. So pancytopenia can sometimes result from folks with advanced cirrhosis. After you've done that sort of reversible, or at least sort of non-malignant workup, if nothing's really coming up, it's really important to think about the bone marrow biopsy next. You need to rule out a primary issue in the bone marrow like aplastic anemia or a bone marrow malignancy, especially when you're seeing macrocytic anemia and at least one other cell line down. That's kind of my general approach when I'm meeting a patient like this. I don't know if you guys have anything to add to that.
No, I think you put that really, really nicely. And I think the thing to highlight here is that you are trying to create a differential that's going to be a little bit more varied, especially when there's more than one cell line that's abnormal. When there's one cell line that's down, certainly the differential and the way that we think about this is a little bit different. But when you start to see multiple cell lines down, you have to at least query the idea that there could be something wrong in the marrow itself. But Dan, I think the way that you laid out that sort of a general approach that I know we've talked about many times on this show about how we approach cytopenias is so critical and something that we shouldn't forget.
So our patient notably had a macrocytosis with an elevated MCV and no anemia starting 8 years ago. He then developed a mild anemia and thrombocytopenia about 2 years ago. So that's really the timeline that Dan was alluding to. That was the first thing that I did here. He had no evidence of liver disease, alcohol use, or other illicit drug use. He had no medication culprits or no over-the-counter supplements that he was taking. We repeated his nutritional evaluation, so vitamin B12, folate, and copper were all normal. He had HIV, hepatitis B, hepatitis C, CMV, and EBV, which were all negative. So we always hear about something called CHIP with unexplained macrocytosis. Let's pretend that we saw this patient 5 years ago. He didn't have cytopenias, but he had a macrocytosis, and we couldn't find a nutritional deficiency. So we have this thing called CHIP. So what are your thoughts at this point, and can you go over this idea of CHIP?
Absolutely. And CHIP and the related topics to it that we'll talk about today are hot topics right now for anybody that's really into the hematology literature like we are. But long-standing unexplained macrocytosis without cytopenias is certainly concerning for an entity known as clonal hematopoiesis of indeterminate potential, or CHIP for short. And so to fully understand this concept, we have to talk about the mechanism of hematopoiesis. And this then will lend itself to understanding MDS and AML a little bit better too. So the key here is to understand a few basic principles, including, number one, that the bone marrow is the cell factory where all the cells are made. And the bone marrow has a long-term and a short-term self-renewing stem cell population that differentiates into multipotent hematopoietic progenitor stem cells. The multipotent hematopoietic stem cells then can become one of two things: common lymphoid progenitor stem cells or common myeloid progenitor stem cells. And essentially, lymphoid becomes B and T cells, and myeloid is everything else. The myeloid and lymphoid progenitor stem cells will undergo several maturation steps and become the final product, which is the mature cell. And it is important to note that there is a significant amount of diversity among stem cells. All these maturation steps require DNA replication, as everybody knows, and the mature blood cells have limited lifespans and will eventually die off, requiring renewal. So over time, it is natural for mistakes to happen through that repeated DNA replication process. And that is when mutations may arise that may be missed by our normal DNA repair mechanisms. The diversity of stem cells protects us from natural somatic mutations that occur with aging and that repeated DNA replication. But often this mutation occurs in the common myeloid progenitor stem cells, so it will be found in all the downstream mature neutrophils, monocytes, etc. So another term that people may hear is clonality, and clonality is defined by the same mutation found in many cells, so we call this a clonal hematopoiesis process. But the clone size is not always large and may go unnoticed because of the significant stem cell diversity. This won't lead to a laboratory abnormality like macrocytosis until there's a significant clonal expansion and an outsized contribution of these mutated stem cells to blood cell production compared to the normal hematopoietic stem cells. So to put this into perspective, there's about 100,000 hematopoietic stem cells contributing to blood cell production. So a single cell with the mutation has to clonally expand to a pretty significant degree before we start seeing changes in the patient. And the last important thing to know here is that we have two alleles for each gene. And these mutations are often heterozygous, meaning that we have one affected allele and one unaffected allele.
So this really tracks with what we know about mutagenesis and how cells evolve and cell lines evolve. We develop a mutation over time by chance after repeated DNA replication in the genesis of blood cells. If that mutation occurs at the level of the myeloid stem cell, then many of our mature cells in the peripheral blood will also harbor that mutation and can be detected with something like next-generation sequencing if we're looking for a panel, of common mutations with that. If we have the same mutation found in multiple blood cells at high frequencies, it's logical to call that clonal hematopoiesis. Mutations that lead to abnormal red cell production and sort of early cell death in the red cell progenitors explains the macrocytosis. Why do we call this clonal hematopoiesis of indeterminate potential? Where did that acronym actually come from?
Now comes the part where everyone zones out, and I do one of my classic historical lessons from the fellow on call. So there were several historical studies that led to the concept that cancers arise from multiple somatic mutations that occur at different times. And the important concept to understand here, as we age, if you were to biopsy the esophagus, you would find somatic mutations in the esophagus. If you biopsy the bone marrow, you're going to find somatic mutations of these hematopoietic stem cells, like Ronak had described to us just a second ago. So the question then became, why do we develop cancer? And one of the pivotal historical papers was published in Science in 1976. We'll link it to our show notes. It's actually a pretty interesting read. So if you have time, I'd recommend reading it if you're a hemonc person. And it described the concept of how one mutation could lead to genetic instability and the development of subsequent mutations leading to cancer. Fast forward to the 2000s, when DNA sequencing became more widely available, it was found that mutations in hematopoietic stem cells could disrupt normal hematopoietic stem cell population dynamics, and this likely precedes the development of a variety of hematologic malignancies, including MDS and AML. So basically, you're going to get one of these somatic mutations in this myeloid stem cell, and Again, there's 100,000 other ones, right? There's a lot of diversity in there. But eventually it clonally expands and starts to take over, picks up another mutation, and then gets more unstable, picks up a third mutation, and then boom, now you have this cancer, like what was described in 1976. For patients with leukemia who were treated and achieved remission, there were a few pivotal studies that showed if you sequence these patients, there was a persistence of mutations in stem cells that were the same mutations found in prior leukemic cancer cells. And the idea was that these stem cells that had the mutation or harbored the mutation may have survived chemotherapy. And for patients who relapsed, these stem cells that had the original mutation, they ultimately had other novel mutations that developed, and then the cancer overtly relapsed. This solidified the idea that there was likely a clonal expansion of stem cells prior to the development of the underlying leukemia. Then comes 2014, which is one of the most pivotal studies that we have in this space. And it was a large-scale population-based study done in the Swedish population for clonal hematopoiesis, and it was published in the New England Journal of Medicine. So researchers performed whole exome DNA sequencing on the peripheral blood of 12,380 Swedish people from a registry that was initially designed to identify genetic mutations associated with psychiatric disorders like schizophrenia. They found that clonal hematopoiesis with somatic mutations occurred in 10% of patients above the age of 65 and only in 1% of patients younger than the age of 50. The most common mutations that were identified were DNMT3A, ASXL1, and TET2, which are also commonly found in our hematologic malignancies. So then the question was, well, how many of these people actually develop a cancer? And the risk of developing a hematologic malignancy for those patients with clonal hematopoiesis was low at about 1% per year, which is similar to MGUS development into multiple myeloma. In a multivariate survival analysis, the hazard ratio for developing a hematologic malignancy, comparing those with clonal hematopoiesis versus those without clonal hematopoiesis, was 12.9. And this hazard ratio of 12.9 sounds really, really, really bad, right? As we've discussed in many prior episodes, when we think about critical appraisal, you need to look at the absolute event rate, right? Sure, it's the hazard's 12.9 higher, right? But what is the event rate? And there was only 0.04% of patients who developed a hematologic malignancy with clonal hematopoiesis. So that's important to understand. Just because you have this, your risk is still quite low of developing a cancer in the future. And so overdiagnosis of this, as you could imagine, could lead to a lot of anxiety and fear among patients. In addition to that, so now we have, well, okay, there are some patients with clonal hematopoiesis. Well, what else does this cause? And in 2017, there was a study done that looked at increased risk of cardiovascular disease in these patients because there was a concern that more of these patients were dying. And the question was why, if it's not from hematologic malignancy. And the researchers found there's a twofold increased risk for cardiovascular disease and overall mortality. So basically what this showed was patients with clonal hematopoiesis have a higher risk of cardiovascular disease. And that was that paper in 2017. The last thing I want to say to round out this historical discussion is that at ASH a couple of years ago, there was a plenary session abstract that said patients with clonal hematopoiesis had a protective effect against Alzheimer's. So it's kind of weird, right? As we age, we pick up these mutations, and for some reason, some patients with clonal hematopoiesis had less Alzheimer's, but more cardiovascular disease, and few of them actually develop a hematologic malignancy. So the question is going to become, how do we identify the patient who's at higher risk?
It's just so crazy to think that all these discoveries have been relatively recently in the grand scheme of science and medicine. And clearly there's a lot of work to be done because, Vivek, as you're alluding to, I mean, there's so many different studies coming out. It's a topic that a lot of people are interested in, and we are still trying to understand really what these mutations mean. You know, from what I've seen, the formal definition of CHIP is defined as having a leukemia-associated gene mutation with a variant allele frequency, and we'll define that term, but a variant allele frequency greater than or equal to 2%, a normal peripheral blood counts, and no diagnosis of any other hematologic malignancy. So basically, to have CHIP, you have to have normal cell counts, and there can't be any other explanation for what's going on. So leukemia-associated genes are simply the mutations that we also find in patients with MDS and AML, and there's no need to memorize this list. But as Vivek mentioned, some of the more common ones include DNMT3A, ASXL1, and TET2. How often do we send peripheral blood or bone marrow next generation sequencing to find these mutations? And is one of these methodologies better than the other? And then I use that term variant allele frequency. Can one of you guys define this? I know I threw a lot at you, but I'm just dying to know.
Yeah, so start with variant allele frequency, because you're right, this is a really important concept to understand when we're looking at these next generation sequencing reports that have become so much more common over the past several years. And this is for both hematologic malignancies and solid tumors. The VAF, which is our abbreviation for variant allele frequency, the VAF is the ratio of mutated alleles to normal alleles. It's that simple. Variant allele frequency, right? This is how frequent is this detected allele found in the patient's sample. So let's go through a germline mutation example to illustrate this point. If we think of every cell in the body as having two alleles, the patient inherited a mutated allele from one parent but a normal or wild type allele from the other, then we would see a VAF around 50% because the mutated allele will be present in every cell. When we're thinking about hematopoietic cells with mutations in the marrow, not every cell that we're analyzing will have the mutation because remember, we have a significant amount of stem cell diversity. There are many stem cells pumping out blood cells. There might be clonal expansion of a mutated cell with a mutation in one of the two alleles, but it would still not represent the entire population. Think about if this mutation that the cell has acquired gives it some sort of survival advantage or proliferation advantage, it's going to have more than its share of representation, but it still shouldn't approach that entire population. So let's say that we have 20% of the cells in the marrow harboring a mutated allele. The variant allele frequency would therefore be 10%. Let's imagine that we're looking at 100 cells total. In this case, 80 of those 100 cells would have no mutation, and 20 of those cells would have a mutation. But remember that there are 2 gene alleles per cell, right? So that means overall there are 160 normal alleles in those 80 cells without a mutation, and 20 normal alleles in the 20 cells that have half of their alleles mutated. That means there are only 20 abnormal alleles. So the ratio would then be 20 divided by 180, which is about 10%. That's how we get that VAF number. So if you're looking at a sample with a VAF of 2%, that means that 4% of the total cells are harboring that mutation. The actual computation that's done for VAF is really, really complicated and doesn't always perfectly follow that rule book that we're outlining just because of the way that next generation sequencing is done. But you can see how things like cellularity, copy number changes, loss of heterozygosity can all play a role in generating that number. And this is why trending a variant allele frequency for treatment response can get really complicated. And it's not as straightforward as just saying, okay, it's coming down this much, which means we've had this impact. That interpretation really should be done in consultation with a qualified pathologist who's an expert in this.
Yeah, and I think it's so important how you explain that variant allele frequency. And you might be wondering, well, let's say that you did a bone marrow biopsy for lymphoma and had some lymphoid cells in there. Why not just send this NGS? How do you know if you send the NGS, how do you know if it's coming from the lymphoma cells or from the background stem cells? How are you supposed to differentiate the two? And what a lot of pathologists say is if you don't have 10 or 20% abnormal lymphoid cells in that population, it's going to be hard to use that mutation that you found and say that that's what was found in the lymphoid cells. It may just be background myeloid cells. And that's the really important thing here. This is a very complicated procedure to really determine these percentages. So Dan, you mentioned that 50% of a variant allele frequency would be germline. Is that? But then you also mentioned that there are limitations to that. So does that always hold true, or at what point should we be looking for something like a germline mutation?
No, it's a great question. Ideally, thinking about this, like if we were purely Mendelian and how our myeloid genes were all inherited, you'd be thinking about a 50% VAF for a germline. But honestly, I think it's really important to be thinking about germline if we're seeing a variant allele frequency of greater than 35%. This also means that if we get an NGS report for a patient with AML or MDS, then a higher VAF mutation is more likely to be that founder mutation, like one of the original ones that set off the leukemia. And these lower VAF mutations that might come up are more like subclones. Basically, if you think about the leukemia cell is dividing really rapidly and it has abnormal internal cellular mechanics, it's going to acquire mutations, and all the cells that arise from those cells that acquired those mutations will branch off and have their own subset of mutations. We call those subclones. For CHIP, for this clonal hematopoiesis of indeterminate potential entity, a variant allele frequency greater than 20% means that the clone has expanded significantly more than normal. And that portends a pretty high risk for additional things coming down the road, which we'll talk about soon. For marrow versus peripheral blood that you asked about, when we're looking for clonal hematopoiesis of indeterminate potential, there's no difference generally in diagnosis because this is a mutation that occurred early in a progenitor, that occurred early on in a progenitor myeloid stem cell. So all the mature cells that we would be able to detect out in the peripheral blood would also have the mutation. So the main difference really would be kind of the sensitivity or how we interpret that VAF percentage in terms of looking at peripheral blood myeloid NGS versus bone marrow myeloid NGS.
All right, that was great. And so remember that this variant allele frequency has to be greater than or equal to 2% to have a diagnosis of this clonal hematopoiesis of indeterminate potential. If it's less than 2%, we actually call that age-related clonal hematopoiesis, and it doesn't have the same implications. That's why that 2% cutoff is important. And how Dan described how we get to that, listen to it again, look at our show notes. It's really important to understand the variant allele frequency, its limitations, and how it's done. And in general, it's just if you have 4% of the cells with the mutation, the variant allele frequency would be about half of that because it's a heterozygous mutation. Most mutations are heterozygous, but there are other factors that could influence that. And the cellularity of the specimen really matters. If you have more of these mutated cells in your specimen, that's going to be a higher VAF, for example. So all of that really plays an important role. So let's get back to our patient. He had a bone marrow biopsy, and that bone marrow biopsy showed hypercellular marrow with erythroid dyserythropoiesis, but no evidence of overt morphologic dysplasia that would be consistent with MDS. Cytogenetic testing was done, including FISH and karyotype, which were normal. And he had an NGS that was obtained and showed a DNMT3A mutation with a variant allele frequency of 28%.
That's really interesting, Vivek, but I do have a question before we proceed, because by definition, what we talked about with CHIP is that there can't be any cytopenias. And you mentioned in the beginning that we actually had seen this guy because of cytopenias. So I'm getting the sense that his diagnosis can't possibly be CHIP, even though he has a 28% VAF with that DNMT3A mutation. So what's going on here?
So when the patient has cytopenias, we call that clonal cytopenias of undetermined significance, or in other words, CCUS. Why do we call this indeterminate potential and undetermined significance? Because not everybody develops a malignancy. So CCUS is essentially CHIP with cytopenias. And it's very important to not just send NGS on every patient with cytopenias or every patient with an unexplained macrocytosis, because we don't know what to do with the information, right? There's no evidence that this will change their quality of life or overall survival. So that's really, really important to know. These are all really being under active investigation currently. You have this diagnosis of something like a CCUS, where you have a CHIP mutation with cytopenias. The question is, what do you do with this? And you offer CBC monitoring and perform a bone marrow biopsy if that hasn't been done, because you want to rule out overt MDS. You wouldn't know if the patient had morphologic dysplasia unless you did that bone marrow biopsy. In general, CCUS can take three paths. Path one, the cytopenias can spontaneously resolve with time, and we just gave them an unnecessary diagnosis. That can happen. Path number two, the cytopenias could persist over many years and never cause symptomatic issues, the most common thing that happens for these patients about 99% of the time, right? Maybe not 99% of the time, but a high percentage of the time that happens. And there's path three, and this is when the patient develops an overt hematologic malignancy, which is actually a rare occurrence. Hence the reason why we don't want to treat everybody with CCUS or everybody with CHIP. I would imagine that we need to think about risk stratifying these patients. So how are we going to risk stratify these patients, and is there any data behind that currently?
This is a $1 million question that's under active research, as you were alluding to. There's no evidence-based guidelines about what to do with that information when we have it. So some patients will have a coronary artery calcium score from cardiology if they have a CHIP mutation, given the doubled risk of cardiovascular disease, but we still don't have definitive evidence of what to do with these patients and the role of things like aspirin or statin therapy. There are several large database studies published from the initial Swedish paper from 2014 that looked to identify risk factors for progression to myeloid malignancy. Findings from these studies showed that multiple mutations, splicing factor mutations, higher VAFs were risk factors for progression, but certainly not slam dunks. This led to a study published in New England Journal of Medicine Evidence 2023 for a risk score for these patients. The study included nearly 440,000 healthy patients from the UK Biobank with information on development of myeloid malignancies. Risk factors were identified in multivariate analyses while controlling for things like sex, smoking status, and a history of cancer. The following risk factors were what were included in that calculator. So high risk factors included splicing factor mutations including SRSF2, SF3B1, and ZRSR2. We will put these in our show notes, don't worry. The other one is a TP53 mutation, and another one was AML-related mutations like IDH and FLT3. Other risk factors in that calculator included VAF greater than or equal to 20%, an MCV greater than 100, an RDW greater than 15%, and the presence of CCUS. One lower risk factor that was identified was the presence of a single DNMT3A mutation. And we'll provide a link to the calculator in our show notes, and you should check it out just to get an understanding of what this really entails. So essentially, it groups patients into low risk, intermediate risk, or high risk. And about 90% of patients will generally be low risk, 9% will be intermediate risk, and only 1% will be high risk. Those with high risk CHIP or CCUS have about a 40 to 50% absolute risk of developing a myeloid neoplasm over the next 10 years. If they're intermediate, it's about 8% at 10 years, and those with low risk is about 0.6% risk at 10 years. For patients with high risk CCUS, it would be reasonable to check CBCs every 3 to 6 months or so to ensure that there's no progression and to determine whether or not there's a need to do a bone marrow biopsy, but there's really no good guidelines when it comes to this. There are also patients that may be candidates for clinical trials, but it's important to have a discussion about the potential for high risk for overtreatment. And repeat NGS testing may not be useful and should really only be done for research purposes in this day and age.
Wow, I'm getting real echoes of our MGUS episode, even down to the percentages, looking at MGUS versus smoldering versus high-risk smoldering. But once we plugged in all of our patient's data into the calculator, he ended up having intermediate risk CCUS. And we discussed observation with the CBC in 6 months and consideration to transition to annual CBCs if he ended up being stable. It's really important to understand this concept of clonal hematopoiesis and that many patients can have low blood counts with a mutation and still never develop an overt myeloid malignancy. If we had this same patient, same exact CBC data and history, but no mutation was identified, then we would call it a diagnosis of idiopathic cytopenias of undetermined significance, or ICUS. Yes, another acronym for us. For those patients, there's no way to risk stratify. We don't have a validated calculator to determine what somebody's risk is in ICUS. We just observe their counts while we kind of rule out the more common and dangerous etiologies. These patients often will have lifelong low counts, but again, we generally think of them as having a low chance of progressing to a myeloid malignancy. It's also important to not just send an NGS test on every patient that walks through the hospital with cytopenias. We're still in the early days of understanding what these mutations all mean, and at present, we don't have enough behind us to avoid a situation of overdiagnosis, which can result in significant distress for the rest of the patient's life without any meaningful change in their overall health outcomes. An unexplained macrocytosis doesn't need to be worked up with a peripheral blood, NGS, and bone marrow biopsy. It really has to be a shared decision-making process with the patient and looking at the overall context of their health. In the next episode, we'll discuss the diagnosis of MDS and AML, as well as how we risk stratify those patients before getting into talking more about treatment later on. So definitely stick around. This is going to be a very rich and impactful series.
Dan, that was a perfect recap. And all I'd have to say is that everybody should keep in mind, just because you have a macrocytosis does not mean we need to send NGS on everybody, because it really freaks people out. And this patient that I'm telling you about, his case, all of this testing led to a lot of anxiety for him. And ultimately, we're not doing anything different other than monitoring his counts. You can also have that conversation with the patient. Why don't we just follow your blood counts? And if they get worse, then we can do the workup. And that is very, very reasonable. So really excited to get into this series. Ronak, anything to add?
I was just going to say, I'm really glad that we started with these definitions, CHIP, CCUS, ICUS. Again, they get thrown around all the time. It's really important that people understand what we're talking about. And the second thing that I just want to plug is just a throwback to our Heme Path series that we recorded very early on in our show. Check this out. It's going to become super relevant for the following discussions that we will be having in subsequent episodes. So in case you need a refresher on cytogenetics and what we look at, fish, all of that stuff, go take a look. It'll make listening to the subsequent series so much easier. But that's all I got. So guys, I think that was a fantastic episode of the Fellow on Call. Until next time, we'll see you all later.
See you later.
Peace.